Good afternoon, everyone. My name is Jamie Block, if you don't already know that. And today I'm very excited to share with you my research on chronic pain management through Project PrEP, which stands for Pain Resources and Education for Patients. But before we delve into the details, I want you to do something for me. I want you to imagine that our friend Jane here is a very real person, a vibrant and energetic young woman in her mid-30s. She loves hiking, spending time with friends, and pursuing her career in law. However, an onset of low back pain began to disrupt her life. Initially, she sought help from her primary care physician, who suggested an anti-inflammatory might be helpful. But her pain has now persisted for well over 2 years, which is over the 6-month threshold to consider her pain chronic. And what started out as low back pain has now progressed to more widespread body pain and an overall feeling of physical and mental unwellness. This experience has left Jane feeling helpless and very uncertain about her future and about whether her pain will ever go away. Over the past 2 years, Jane encountered numerous obstacles in navigating the complex landscape that is chronic pain management here in Canada. But what is arguably more unfortunate is that Jane's fictional story mirrors the very real experience of countless other individuals grappling with chronic pain, feeling lost in a system that often lacks comprehensive solutions. But for now, let's understand the current state of chronic pain here in Canada. Currently, 20% of Canadians aged 18 plus report experiencing some form of chronic pain of varying origin. That's roughly 6 million people here in Canada. Unfortunately, for many reasons, chronic pain is still poorly understood and even more poorly managed by our healthcare system, resulting in the increased prevalence of chronic pain across all demographics and a statistically significant rise on attempts of suicide and suicidal ideation in this subpopulation. Despite plenty of research supporting the idea that an integrated and interdisciplinary approach to managing chronic pain is the best solution we have to date, the incidence of properly managed chronic pain using an interdisciplinary framework still remains remarkably low. But it's important to distinguish between multidisciplinary care and interdisciplinary care. Multidisciplinary care involves specialists working independently within their expertise, often lacking close interaction. Interdisciplinary care, however, integrates various specialties, fostering collaboration, shared expertise, and cohesive patient-focused strategies. Importantly, interdisciplinary care surpasses multidisciplinary approaches by promoting deeper collaboration and a more holistic understanding of chronic pain. It ensures a more comprehensive treatment, considering multiple perspectives for better patient outcome and improved quality of life. In summary, while both approaches offer valuable insights, it's the interdisciplinary care's unified and integrated nature that proves far more essential in effectively managing chronic pain. But chronic pain isn't just an individual experience. It's felt throughout society, resulting in a significant economic burden. For individuals, it translates into more than just physical discomfort. It often brings about substantial financial strain. Lost income due to inability to work, coupled with substantial out-of-pocket medical expenses, creates a formidable financial challenge for those grappling with chronic pain. Simultaneously, the broader societal impact is profound, as reduced work productivity among chronic pain sufferers contributes to an economic loss at a societal level. The economic impact of chronic pain in Canada, encompassing healthcare expenses and productivity loss, was estimated at approximately 60 billion Canadian dollars based on the 2020 report from the Canadian Pain Task Force and further validated by Sierra Medical Services, a prominent national provider of independent medical evaluations. Through the lens of lived experiences by myself, personal encounters of other lived experiences, and extensive literary evidence, some realities reveal themselves. Effective help and support for chronic pain sufferers are far too scattered. The nature of our healthcare system often leaves individuals navigating the journey alone, encountering significant hurdles in finding adequate support and effective treatment. The apparent lack of guidance in coordinating this interdisciplinary care further compounds the challenges for the patient, leaving them to grapple with fragmented and disjointed management of their condition. This lack of coherent guidance significantly diminishes the probability of adopting an interdisciplinary approach that truly encompasses biopsychosocial care, which is a comprehensive method recognized as pivotal in addressing chronic pain. Consequently, this reduction in the likelihood of adopting a holistic approach likely translates into lower probabilities of positive health outcomes for chronic pain patients. Well, so what? I've presented you with a lot of information. Well, there's a very clear need for a greater adoption of interdisciplinary care for patients with chronic pain. And here at the Translational Research Program, we like to talk a lot about the problems that drive the gap between our current state and our desired state. And there are two problem statements that sort of rise up quite quickly. Firstly, chronic pain patients struggle to advocate for interdisciplinary care due to the fragmentation of resources, fear of physician dismissal, and the overall complexity of the healthcare system. And secondly, the overwhelming challenge of actually organizing the necessary care exacerbates the issue, leaving patients feeling lost and often leaving them to resort to arrange their own care without proper guidance. Which leads me to my research question. How can technology be leveraged to aid in personalized interdisciplinary chronic pain management? Which then leads to the overall objective of the study. The objective of Project PrEP was to investigate the challenges and opportunities in chronic pain management through stakeholder collaboration, culminating in the co-development of a user-centric mobile health solution. But how did we do it? In other words, what was my methodology? Well, my methodology is split into three phases. Phase one were the semi-structured interviews. The purpose of these interviews was to mobilize patient knowledge to deeply understand their individual challenges and barriers to successful pain management. In terms of participant recruitment, we were looking for 15 to 30 adults from the Greater Toronto or Greater Hamilton area with pain lasting at least 6 months, as this is a standard accepted duration to be considered chronic. We used convenient sampling with multiple streams of advertising, including posters on the TTC subway, as well as multiple healthcare clinics around the GTA. And participants that reached out were first screened for eligibility and subsequently interviewed if they met the criteria. Phase two was data collection and analysis. I used a qualitative data software known as InVivo12 and used that to conduct a thematic analysis of the interview transcript data. This formed the foundation of our analysis and allowed for the translation of the knowledge we learned into our final project outcome, pain base. And our last phase is phase three, which is wireframe development. For those who don't know, a wireframe, also known as a page schematic or screen blueprint, is a visual guide that represents the framework of a website or application without having to develop any software. We designed the wireframe based on two major streams of information. Firstly, functions validated by app users in similar applications currently on the market, as well as novel features requested by the Project PrEP interviewees themselves. I used the Figma and Miro platforms for the visual development of the wireframe and ensured regular engagement with the project advisory committee to ensure that the project objectives remained at the core of our mission. In pursuit of creating Painbase, a user-centric solution, we arrived at an important phase, user testing. To ensure an effective design, we engaged individuals previously interviewed, actively involving them in our development process. Adopting a Wizard of Oz style approach, our user testing sessions allowed participants to engage with Painbase's wireframe, providing real-time feedback as if they were interacting with a fully functional application. This pretend interaction facilitated a unique perspective, drawing upon their real-life experiences in chronic pain management and app usage. Their comments and suggestions were recorded directly into the wireframe in Miro. This feedback served to support the continuous refinement and iteration of the wireframe development. Now let's talk a little bit about the results and outcomes of what we learned. The first thing to mention is that all participants were asked to complete the Pain Disability Index. This is a high-level 7-question questionnaire that's designed to measure the degree to which aspects of one's life are affected or disrupted by chronic pain. We asked the participants to do this to gain a high-level understanding of who exactly it was we're dealing with and how bad is their chronic pain. Now, the PDI data didn't show significant trends, but it did highlight considerable diversity in the chronic pain experience. And despite no groundbreaking findings, the individual heterogeneity emphasizes further the need for personalized chronic pain management approaches. Now let's trace the path leading from raw qualitative data, in other words, the patient interview transcripts, to uncovering pivotal themes. This approach, known as thematic analysis, acts as a compass of sorts, guiding us through the intricate narratives shared by individuals enduring chronic pain. Beginning with these unprocessed narratives and employing an inductive coding process, we structured a code book to sift through details of our interviewees' stories. These codes act as puzzle pieces, unveiling nuanced and essential components within the chronic pain narrative, resulting in 16 codes with varying nested subcodes within each. But these themes don't exist in isolation. Rather, they converge into major overarching pillars that form the foundation of searching for and managing interdisciplinary care for chronic pain. Rooted in interpretive description, championed by Sally Thorne, this method offers a framework for understanding qualitative data. It goes beyond mere description, enabling me to interpret and synthesize narratives, culminating in the emergence of these essential pillars. Let's now pivot our focus to these major pillars I just mentioned. The first is discovery. Discovery emphasizes the necessity of self-education and access to comprehensive information for effective pain management. And I've included some quotations here that outline that. Learn all you can and ask all the questions. It really is a self-advocacy situation. By the way, these are all quotes directly from the interviewees. This first quote underscores the necessity of self-education and advocacy in navigating chronic pain management. It highlights the challenge individuals face in proactively seeking information and resources to understand their condition and available treatment options. The emphasis on self-advocacy reflects the need for individuals to take charge of their healthcare journey, indicating the hurdles in accessing comprehensive information and resources. Certain activities was causing me to flare, and I didn't know what a flare was, and I still don't. Here, the quote reveals the challenge of lacking access to accurate information about chronic pain symptoms and terminologies. The individual's lack of understanding about what constitutes a flare, in this case, signifies the gaps in knowledge and information that chronic pain sufferers may encounter. This gap in knowledge hampers effective self-management, making it difficult to identify triggers and appropriately respond to changes in symptoms. And lastly, I'd never heard of an osteopath, and I had no idea what they did or how they could help. This quote further highlights the struggle of accessing information about complementary therapies for chronic pain management through allied healthcare. The lack of awareness about the role of certain allied healthcare professionals in pain management indicate the challenges individuals may face in exploring and understanding various treatment modalities beyond conventional medicine. This lack of information poses another barrier to individuals seeking effective avenues for pain relief and management. This last quote supports the argument that allied healthcare is not only important in effective chronic pain management, but is often necessary. Through this study, it has become more clear that those who sought out allied healthcare in conjunction with traditional allopathic care yielded more positive results. However, given the low sample size of participants, I hesitate to draw any significant conclusions with respect to this, which brings us to our second major pillar, managing. This highlights the challenges individuals face in organizing and handling various aspects of chronic pain management on their own. I don't think at this point in my life I'm trying to get the pain to go away. I'm just trying to manage the pain. This quote underscores the struggle in finding the right practitioner or treatment that provides substantial relief. The individual's focus on managing the pain rather than eliminating it reflects the difficulty in seeking effective therapies that last. The constant search for a solution and the acceptance that complete pain relief might not be achievable indicate the challenges faced in finding a treatment that does offer lasting relief. When I asked one participant about their particular difficulty in seeking out interdisciplinary care and also maintaining a positive attitude and mental state throughout the process, they said, it drains the energy from you, like fully. It's already like you have World War III kind of going on in your body, and you're drained mentally. Here, this quote illuminates the daunting task of maintaining a consistent and coherent medical narrative across various healthcare practitioners. The mental and emotional exhaustion caused by chronic pain makes it challenging for individuals to consistently convey their story, symptoms, and medical history accurately to each new practitioner. This struggle to keep a consistent narrative poses a significant hurdle in receiving comprehensive and cohesive interdisciplinary care. Being sent to so many different doctors, having to repeat myself over and over and over again, forgetting, because I've been on this journey for so long. This quote highlights the need for a central and organized location to manage appointments, medications, treatments, medical history, and more. The constant referrals and visits to multiple doctors and healthcare practitioners also underscore the fragmented nature of chronic pain care here in Canada. The struggle of repeating one's story due to memory strain and the lengthy duration of their chronic pain journey accentuate the necessity for a centralized system that efficiently stores and communicates crucial medical information across various healthcare providers. And lastly, we arrive at our third pillar, connecting. This underscores the vital role of social support networks in coping with chronic pain, particularly through peer connections and support groups. And in this regard, I think one quotation stood up above all else. Going through chronic illness is hard, and going through it kind of without the support of others there is even harder. Not only do I empathize with this sentiment from my own lived experience, but I would further argue that going through chronic pain without the support of others is near impossible. With those three pillars in mind, discovery, managing, and connecting, we arrive back at Jane. In our desired state, Our friend Jane here would have been able to discover more about her options in chronic pain management, manage all the moving parts effortlessly, and connect with others who can support her path to successful pain management through the use of a user-centric application like Painbase. The Painbase application wireframe was designed with the insights gained from our research, keeping the needs of the target population at the center of all of it. While it would take a very long time to go through every current working page of the app's wireframe, I find it prudent to share some examples of current wireframe pages that exemplify the Discover, Manage, and Connect framework. So let's discover. Here on the Discovery homepage, we can learn about certain practitioners that exist in the chronic pain management landscape, other chronic pain conditions, common medications that are prescribed, mental health resources and mindfulness tools for chronic pain, therapies that are available, self-advocacy resources, current research, as well as healthy habits. If we further delve into the discovery side of things, here I've included a list of practitioners that are involved in chronic pain management, ranging from allopathic practitioners to allied healthcare as well, and everything you need to know about that practitioner and what you need to prepare for them. As well, there were a lot of concerns amongst the participants about medications. What do my medications do and how do they work? And do they even interact with each other? Here you can see a list of common medication categories for chronic pain management, as well as a link to a drug interaction checker to help ease the worries of those worried about interaction among their many drugs that they might be on. Here we get to the Manage homepage. Let's manage. On the Manage homepage, you can have access to your symptom tracker, your appointments, medications, exercises, history, and reports that you can share from one practitioner to the next. As we further delve into the management side of things, I've shared with you the Find a Practitioner page. This will help you find a practitioner within your locale, being able to filter for distance from you in case you have issues with mobility, the type of practitioner you are trying to look for, the language of practice, and other parameters that have yet to be included, such as gender-affirming care. As well, right next to it, we see what your upcoming appointments might look like. Here you can see that Jane has an appointment with Thomas Hein, a physiotherapist. They also know when it is, where it is, and how to potentially prepare for such an appointment. Finding a practitioner potentially holds the key to this whole operation in terms of potential commercial sustainability. Let's connect. Here on the Connect homepage, you can see that you'd have access to browsing current discussions, posting a new discussion, and access to support links. Through the current discussions, you can see that we have an individual here, a young folk, who's created a post about dealing with social stigma as a young person who's been diagnosed with chronic pain. He's reaching out to the community, hoping for empathetic responses and hoping for some guidance from others with lived experience who may have dealt with similar issues. Further on in the connecting framework, we see links to in-person and virtual support groups here within the GTA, in case individuals who use the platform want that extra little bit of support from people who have lived experience. In terms of direct future steps of the project, a development of a minimally viable prototype that can be further tested by end users is essential, but this is going to require time and money. And we're also looking to publish the final report and manuscript associated with the study. Now, no study comes without limitations and challenges. Our limitations are split into two major limitations, sampling and geographic location. Sampling is further stratified into size issues. So with respect to size, there were 16 individuals that were interviewed. Now, while that's satisfactory in terms of reaching data saturation from a qualitative standpoint, from a quantitative standpoint, the sample size is likely not large enough to draw significant statistical conclusions about the larger chronic pain population. And sampling. The sampling strategy utilized in Project Prep inherently did not account for individuals with chronic pain who have severely limited mobility or no mobility at all. Therefore, the outcomes of this study do not necessarily reflect the challenges and barriers to effective pain management that may be experienced by those who have exceptional physically debilitative pain. Second, geographic location. 100% of the participants were either residents in the Greater Toronto or Greater Hamilton area, and there was therefore no representation of individuals from rural communities. So the results and conclusions from this study may also not be applicable to that subpopulation of people who live in rural areas, where access to certain healthcare options may be limited or completely absent. With respect to challenges, well, I was a solo principal investigator, a party of one. And this was challenging for many reasons, but mostly it meant that there were fewer eyes and ears on the project, which resulted in a whole slew of other challenges. There was no opportunity for delegation of tasks, which resulted in a fair amount of mental exhaustion and doubt with respect to whether or not I was leading this project in the right direction. As well as being the only one conducting the interviews, The interview stories were quite sad and very heart-wrenching at times, which affected me greatly. Emotional self-care became an essential part of keeping my composure both during and after participant interviews. And lastly, heterogeneity. Heterogeneity equals complexity. Because the experiences of individuals with chronic pain are so unique, it became a considerable challenge trying to sift through each story to A, search for common struggles amongst the participants, and B, determine if the common struggles identified do in fact align with what I learned during the preliminary stages of the project, both through the environmental scan and literature review. And now for some lessons learned. Firstly, it's the personal stories and lived experiences that hold the power to reshape our understanding of what it means to deliver healthcare and drive innovation. Secondly, we talk a lot in the TRP about the necessity of pivoting. I've now learned firsthand the value of pivoting in applied research. Remaining flexible kept my project relevant and allowed me to respond to new insights. And lastly, I was a solo PI, but I was never alone. With that sentiment in mind, I'd like to make some acknowledgements to the people who made me feel not so alone throughout this process. To my three TRP supervisors, Dr. Edita Marcon, Dr. Joseph Fehrenbach, and Dr. Rich Fody. To my amazing project advisory committee, Lisa Goodman, Thomas Hine, and Dr. Gordon Coe. To my incredible research assistants, Sammy Squared, Samantha Gold, and Samantha Belitsky. And to my two research associates, Natalie Trin and Stella Rowe. Thank you so much for your support throughout this entire process. And to my family and friends who listened to my seemingly endless venting sessions throughout this project, but nonetheless continue to be by my side, supporting me and cheering me on. Thank you.